I will tell you that the sort of the energetic tenor in the room went down pretty drastically. It went back up pretty quickly thereafter. I'm not going to lie. I'm not going to tell you that I have some kind of magic spell, but for about a minute there was this quietness to his nervous system. Oh, okay, so you're telling me from a medical perspective, you're not wrapped up in this emotionally in the way that I am. You're telling me your medical perspective of what you think is the next best step. By the way, I was suggesting residential, which he was not happy with. So you're basically saying that I'm a junkie. Anyone else want to read? Yeah, let's have another. Although if no one else is going to volunteer, go for it. I'm saying that addiction is a medical problem that responds to treatment, not a problem of bad morals or behavior. Validating, decreases the emotional tenor in the room, soothes the nervous system, and also offers, remember when we go back to that VIMA piece, it offers some validation saying that, hey, there's a treatment for this. Rather than saying you're a junkie, or not that we would ever say that, but saying, hey, you're struggling with addiction, I'm not going to refill your opiates anymore. It says, hey, I think you might be struggling with addiction. I have resources that I can offer you to deal with that. Rather than just saying, here, that's the end of it, I'll see you later. It's very validating. How about this? Do you want me to lose my job? Do you want me to be on the street? And again, this is the one that always gets me, except it's about kids. It's like, do you want me to not be able to parent my kids? Oh, my heart just like, somehow people know that that's the one for me. So, anyone want to read?
Want you to have a safe and effective pain control, and it is my medical opinion that your current medication or current medicine won't give you that.
Yeah. So again, it's really coming back to this medical role. It takes some of the emotionality out of it, it decreases things in the room, and it also gives you a moment, if we can go back to that elicit, provide, elicit, it gives you a moment to say, here's what we do know, can I share some feedback about what the research says around opiates? And it gives you a moment, if the person is able to hear it, it gives you a moment to say, what we actually know about opiates is that they probably aren't very useful for chronic pain, and maybe they actually make functionality worse. So it actually gives you a teaching moment. The next one is the patient saying, do you have pain? I've actually never had anyone in my room say, do you have anxiety? And yet I love Brad's response, and I've always planned to use it. I want to take every minute of our time today to talk about your pain management plan. See how that's like quickly deflecting and kind of moving around the statement, and yet also really validating at the same time? So instead of saying, well, yeah, I do have pain sometimes, or saying, no, I absolutely don't have pain, it just doesn't even address what the patient is trying to get at. It steps right around it, and then very validatingly and very medically says, how do you want to spend the rest of the visit today? I really want to spend the rest of the visit talking about your functionality and your safety, essentially. And then the patient says, I wish you could feel my pain. I know you're suffering, and I'm sure that we can work together to reduce pain so that you don't have to suffer. See how validating that is? Going back to that VIMA, it really validates saying, I believe that we can do better. I believe that you deserve better, and I believe that if you engage in treatments, we can do better, as opposed to saying, I'm just not going to give you opiates anymore. Policy says so. How about if we get into the realm of threatening? I heard it's illegal for you to let me go into withdrawal. I actually hear this one all the time, right? With benzos, in some ways far more significant when it comes to withdrawal than opiates. So I get into this conversation with patients all the time. Well, you can't let me do that. You can't let me go into withdrawal. By the way, I would never actually let someone go into withdrawal. But patients often feel like we've tapered too quickly, etc. So this one only works for opiates. Someone want to read it?
Withdrawal is uncomfortable but not life-threatening. I can prescribe you medicines to help with the withdrawal symptoms.
Yep. And so I would say one of the things to take away from today is to make sure that you have kind of a withdrawal toolkit. So what are those medications that you pull out every time someone is in withdrawal? Because it's really nice to say, I can give you this for the shakes, I can give you this for your stomach, I can give you this to help you with sleep, so that that patient experiences validation and that you know how to help with that immediately. I'll just go and use heroin.
I certainly hope you don't, because you know that I don't think any type of opiate will help your pain.
I love that because it takes away this threat, right? The patient is trying to sort of rope you in, trying to rope in the emotions here. I don't want to use the word manipulate, but there certainly is, they're trying to rope you in this moment. I hear it pretty regularly. And the safest, most compassionate thing to say, of course, is to kind of decrease that and say, of course, I don't want you to use heroin, but mostly I don't want you to use it because I don't think it's safe and I don't think it's actually going to help. I'm getting a lawyer, I'm calling KGW. The response is you do what you feel is right, of course. That's what I'm doing for you too. You have a family doc, don't you? So if people actually get into the realm of threatening, then it's time to involve the police. So last note, boundaries really do make everyone feel safer. So when we talked about sort of protecting ourselves, this has become one of my favorite lines. And I do it a little bit differently than Brad does. I think Brad says, I can't remember what Brad says, but my line is opiates or benzos generally are off the table. How else do you want to spend our visit today? Because often you get into this sort of power struggle around where's this conversation going to go? Maybe the patient I had yesterday, my sense is that he thinks that if he can finally say the right thing, that I'm going to change my mind. And this tells the patient, there's nothing that you can say that's going to change my mind. And I'm still totally present with you and I still want to help you. Those medications are off the table today. How else do you want to spend our visit? Or what else could we talk about in your chronic pain management plan? Very validating, very present, very patient-centered. And at the same time allows you, I don't want to say an easy out because it's not an easy out, but it allows you a way to step back from that conversation that often is getting heated. And I don't know about you guys, but it's often circular, right? You're just going in a circle with this patient over and over again. There is nothing you can say or do to make me prescribe you opiates or increase your dose or give you an early refill. Again, allows you to step back from that conversation, stops that kind of circular motion. And then I think the suggestion is there's nothing you can say or do that it's going to change my prescribing, etc. How else would you like to spend the time today? So really come back to being present and being patient-centered in that moment. So we've got just a couple of minutes. What are you guys going to take away from this? Just some quick, just popcorn out some things that from this, some of the skills we talked about, you feel like you might actually use in your practice. Safety? Yeah, absolutely. Yes, I'm so glad you said that because if there's one thing that I want you guys to take away in those difficult conversations, it's to come back to safety. You don't know where else to go with this conversation? Come back to safety. Yep. Patient-centered approach. Yep, good. Boundaries, yeah. I love that you said that because I think something I forgot to mention was, sometimes I think that, especially people that are socialized as women, but we often think boundaries are mean or like boundaries are going to create conflict. Boundaries actually are one of the most loving things you can do for yourself and those around you, especially patients on chronic opiates. Having boundaries is going to make everyone in that room feel better. Yeah, absolutely. You're right. I hadn't thought about it that way, but you're absolutely right. Yeah. I saw a hand over here.
I think they'll rely less heavily on explaining the policy.
Mm-hmm.
Not to kind of rely on that too personal. It's not me, it's the policy. People don't like that policy too much.
Yeah. Yeah.
So, but it's clear that the patient feels like maybe more of a statistic than they feel of a individual. So help them find someone else.
Yeah. Yeah. Me too, because I tell them about the policy, and what they don't know is that that's you that wrote the policy. And often I've already made a decision, and I've already sent it to the Controlled Substance Committee saying, I don't think this person should get this. But for years, I did this as kind of this slippery, like, oh, I'll advocate for you. And now looking back, like, that's really not transparent, right? That was just me trying to avoid this really hard conversation and actually does nothing for the patient, just makes me feel a little bit better when I go home at night. And so when I've shifted to really focus on safety rather than the policy, things go much, much better. Any other takeaways? And then I'll pass it off to Melissa. Okay, thanks you guys.